Modern healthcare across the US and Europe is built as a massive, centralized monolith. Structurally, it fractures under its own weight. This monolithic design forces everything from brain surgery to floor maintenance under one roof, hiding liability beneath layers of bureaucracy. Inefficiency and nepotism thrive because the architecture is too large to fail and too opaque to audit. To prevent collapse, the current system relies on the Hippocratic Oath, a fragile, unscalable hope that individual human conscience will act as the ultimate quality control mechanism. Statistical reality suggests otherwise. Any system built purely on the moral conscience of its operators inevitably yields to corruption, as individuals adapt to whatever behavior the immediate environment rewards. We cannot simply standardize morality. True accountability requires completely re-engineering the system's core mechanics to mathematically force good outcomes. We should treat healthcare as a rigid software architecture in need of debugging. Stabilization requires a negative feedback loop, a self-regulating mechanism where bad inputs are automatically neutralized by systemic consequences. Building this requires two radical steps: decoupling physical buildings from medical talent and instituting an algorithmic pricing mechanism. This architecture makes medical negligence so financially ruinous that it becomes functionally impossible to practice bad medicine. A primary operational flaw of the current system is forcing highly specialized surgeons to manage building infrastructure like heating, cooling, and janitorial staff. The first systemic fix involves severing the physical infrastructure, the hardware, from the medical talent, the software. Hospitals become private real estate entities tasked only with maintaining pristine building hygiene and operating heavy machinery like MRIs. Practices function as independent mobile teams of professionals, surgeons, anesthesiologists, and nurses, packaged as a single roaming unit. These practices rent specific time slots in different hospitals based strictly on their immediate surgical needs. Severing these roles forces each entity into pure specialization, eliminating administrative bloat and turning operating rooms into a competitive rental market. Decentralizing medical talent raises a critical question. If doctors are independent contractors, who prevents negligent work? This requires the third architectural pillar, the Independent Medical Inspectorate. These are private firms comprised of retired doctors, pathologists, and economists who no longer perform surgeries. The inspectorate serves one function: automatically intercepting and reviewing the pre-op and post-op data of every single treatment. They evaluate the biological success of the procedure using a strict 1 to 5 grading scale. Removing the power of evaluation from biased doctors and subjective patients guarantees cold, objective, data-driven accountability. Measured, analytical, algorithmic pricing acts as the core negative feedback loop, translating the inspectorate's biological grade directly into financial physics. A perfect grade 5 triggers the maximum possible payment from the National Health Fund. A grade 1, representing negligence or botched procedures, penalizes the doctor 10 times the maximum procedure price. Inspectorates receive a 20% cut of this penalty fee, incentivizing them to catch every instance of malpractice. This algorithm binds patient recovery to the surgeon's financial survival, making negligence a literal bankruptcy event. This creates an immediate loophole. An inspectorate could issue fake grade 1s to harvest penalty bounties. To prevent this, a super inspectorate is triggered whenever a penalized doctor appeals a grade 1 rating. If the super inspectorate finds the original firm incompetent or corrupt, the inspectorate must pay the 10 times financial penalty. The falsely accused doctor is then compensated with a 20% payout from that penalty for the disruption of their business. This creates a perfect three-way standoff. The inspectorate is trapped between the greed of catching errors and the terror of being caught lying. Strict mathematical physics permanently alters the daily behavior of individual surgeons. Knowing a single failure could bankrupt them, surgeons will proactively refuse cases outside their exact expertise. Hospitals are forced to maintain pristine, infection-free environments because independent practices will refuse to rent dirty rooms that jeopardize their surgical grades. The architecture weaponizes self-interest to produce the highest possible standard of patient care. The system relies on 3 distinct layers: the decoupling of infrastructure, objective third-party grading, and ruthless algorithmic pricing. This environment removes the need to hope for the inherent goodness of hospital administrators or doctors. Societal reform emerges from applying relentless engineering to human biology, creating an environment where excellence is the only mathematical path to survival.